We invite Dr. Sugato Paul with his topic Mishap with the Canula. Sugato.
So it's actually mishap with my pen drive, so they couldn't open the pen drive, so I have downloaded the video, and it's two videos actually. Please move it to 15 seconds. So it's yeah. So stop there. So just 1 second. This is a separate video where I am rotating a lens on the PCR. I did tell you to set it at 15 seconds. Where is it? Okay, yeah, so here is a case, straightforward case, where I'm in, after the section, I'm injecting a timer, injecting OVD, and just keep and watch. The OVD is going in and the cannula went in. It just came out of the liver luke cannula. Liver luke didn't function. It just went in, and you can see it's hitting the capsule very hard. So what will you do next? So main point here, I think, is to assess how much damage it has done. Quite often it can hit the angle, can cause hyphema. Quite often it can hit the capsule and cause a tear in the capsule. So that's what it happened. And you can see the cannula is a liver cannula where you can lock the cannula. In spite of that, probably the nurse didn't lock it properly, but luckily I do, as a habit, keep my finger at the end of the cannula, so it didn't go that hard. So then I switched on the Lumira eye retroillumination, and I could make out that capsule has run out there. So what is not playing? So what can we do next? So there are options of, in this situation, what you can do. First, decide whether to convert to phaco or stay with phaco or to convert to ascites, and it depends on the surgical acumen or the confidence of the surgeon. And here I decided to go ahead with the phaco. So the first thing you have to do is to get good access to the nucleus. So I did give a cut to the extension with the venous scissor and then got a good extension. Now, hydrodissection. Hydrodissection should be minimal so that it doesn't extend the to the posterior capsule. And rotation of the nucleus is better to use. As you can see, I'm using two sharp choppers, so that no force during rotation with single chopper or single dialer, no force is put on the zonule. So I'm using two choppers to rotate the nucleus gently. Next is your working area of the phaco. As you can see, my extension was here. So I've directed my phaco tip almost perpendicular to the extension, so that again to minimize force on the extended area. So this is one point you have to remember, and you have to be very gentle. The one thing you can do actually is to do anterior planar phaco by moving the nucleus out of the bag, but here I decided to stick in to the posterior chamber phaco. So first chop is done, and again, if you can see, while rotating, I am rotating with the help of the phaco tip. I am using as a hinge, and I am rotating with the dialer, so that again no pressure is put on the zonule. So now once the nucleus is rotated, I am getting a second chop done, and then again rotate. I am hinging on the phaco tip and rotating with the with the chopper very gently, and I am getting another chop. So two pizza pie, once two smaller pizza pie is done, then you can take out the nucleus and you can do other, you can do chops of the other half of the nucleus and can gradually take it out. So then it becomes easy. Again, at this stage, you have to look for with umbilical sign whether there is fluttering of the anterior capsule extension. So you have to remember, if there is fluttering, chances of the wrap-up tear is not there. But if the fluttering has stopped, then the chance of wrap-up tear is there. then you have to think of your second option of converting or bringing the nucleus into the anterior chamber. So once this is done, the next point you have to remember, don't take out your phaco tip suddenly. Fill in with the visco, the chamber is formed, no chance of extension, then you take out the phaco tip, and same thing you have to do while doing IA as well. While doing IA, you have to be careful not holding the extension of the capsule, gently pull in the center. Now regarding the lens choice, timer? No. Regarding the lens choice, three options are there. One second. One is 3-piece IOL, which was not available at that time. Second is single-piece hydrophilic. Third is single-piece hydrophobic. Now, don't put a 3-piece IOL in the bag in this situation, because the haptic will find way and go out to the extension. So if you are putting 3-piece IOL, put it on the sulcus. But if you are putting single-piece IOL, try to put it in the bag, remnant of the bag, which I have done. And then I have used pilocarpine to make the pupil small and see that the pupil is round, and finishing the case. Thank you very much.
Any discussion on the topic, please? Any question?
With your excellent skill, you passed your 10 minutes with all the apprehensions and with your strategies. But what message you are saying to common average skilled surgeons?
I am an average skilled surgeon, sir. If we follow the techniques like not doing the phaco where it's extended, not rotating the nucleus hard where the zonule is pressed, with the 2-tip I'm rotating, so no pressure is on the zonule. And then you have the scope of bringing the capsule nucleus up in the anterior chamber. And third thing, you have to get rid of the ego if required, convert to SICS.
I think one important thing which we have noticed in his surgery, the lateral separation was minimal, just to get the space, just to get the crack. Because if you try to make a lateral separation quite a bit, then there are chances that that tear will extend. Otherwise, minimum stretch on the zonules, what he is trying to emphasize, also means that lateral separation should also be just adequate to get the two halves separated.
So
do you reduce the settings as well as by doing the environment?
Honestly, no.
You do in the same settings?
Yes.
So
Was it the pressure was swing? Normally nowadays I start phaco with 20 pressure. IOP sometimes goes up to 32 depending upon the chamber stability. Otherwise, no, I don't change.
not even the bottle height, sir?
No.
While doing the nuclear management,
Yes.
were you doing it in the bag or in the
It was in the back. That's what I
because
said.
sometimes doing it is like
Yeah, you can. That's
in
another
antechamber,
second option is you can
it
take
is
it in
safer-
the anterior chamber.
safer
It
to-
was a hard nucleus, so I thought I'll stay in the chamber, and if required, I can bring
because
it
it
up.
will put more pressure on the capsular bag.
Yeah, that's why I'm rotating, as I've shown, I'm rotating with 2 hooks. And also while during the phaco, I'm hinging with the phaco tip and rotating against that. So I'm not putting any pressure on the zonules.
That is a very good technique. That is very
Sorry? Yeah, I did show you that I did cut with the venous scissor and then did the hemerexis. I did show it.
Notch is always there, Notch
that is
is there.
open. That is open.
unless and until your tear was not beyond 6 millimeter in the radius portion. Then you can probably circumvent that, and then it will be uniform. But
It
otherwise,
was on the equator, so that was open. Thank you.